milligram per liter, milligram per gram, so it is very confusing. What is albumin, what is protein, how to interpret these reports when they are presented to us. So it was decided, Dr. A.C. Agrawal and I decided that the first talk should be of this very important topic, a lab report, microalbuminuria. So we will just go through what is it. So for that we have to understand the glomerulus, the nephron. So this is the cartoon of a nephron, and this is the glomerulus. This is the afferent arteriole, and this is the efferent arteriole, and then this is the proximal tubule. So you all know that all the blood, the cardiac output, that is 120 ml per minute of cardiac output reaches the glomeruli, and it is filtered. So in the one whole day, 180 liters of filtrate is there. But proteins are also filtered from here. Then the proximal tubule reabsorbs most of the proteins, or it degrades them. So the final urine contains not more than 20 to 150 milligram per day of protein, and mainly it has albumin. So you see the magnitude or the important role the glomerulus plays, that we all know that the plasma concentration of the protein is 70 gram per liter. That is, we see the report 7 gram per dl of protein is present. Renal plasma flow is 625 ml per minute. So if we multiply it, 625 into 1440, that is the number of seconds in one day. So it amounts to 900 liters per day. This much of plasma is presented to the kidney in one day. So the protein delivery per day would be 70 gram into 900, that is 63,000 gram per day, or 63 kg per day of proteins are presented to kidney. But amount which is secreted finally is less than 150 milligrams. So again, this is the glomerulus. This is the lumen of the capillary, glomerular capillary. This is the endothelium. This is the basement membrane, and this is the epithelium of the glomerular capillary. So this is a huge epithelial cell, and these are the podocytes of the epithelial cell, and these are the fenestrations. Then there are so many barriers for the protein to escape the glomerular flow, blood flow. So these from the endothelium, from the basement membrane, from the podocytes, all are present a barrier for filtration of proteins. Further, if we want to understand it better, so all the small solutes and molecules, they pass freely across the basement membrane. Low molecular proteins like beta-2 microglobulins and free light chains also pass through. Albumin, which is also a relatively small molecular weight, 69 kilodaltons, this also filters through the glomerulus, but in the proximal tubule, it is reabsorbed or it is degraded. So finally, the albumin should never be more than 30 milligrams per day in final urine. The tubules secrete protein, and the commonest we all know are 10 horsepower proteins. So this is the kidney in health. This is the blood. All the albumin are retained over there. The urine is clear and free of proteins. And this white line is the barrier, that is the glomerular membrane, endothelial cells and the epithelial cells. To pass through it, and they will appear in the urine. So therefore, it is right to say that urine albumin is a marker for kidney damage. Whenever the basement membrane's integrity is breached, albumin starts appearing in the urine. And abnormal urine albumin level is a marker for glomerular disease, including diabetes. It is a marker of generalized endothelial dysfunction, and it is associated with increased mortality independently. test urine in our day-to-day practice. One is the dipstick method. It is a semi-quantitative method. It screens. It is affected by various factors: the pH of the urine, whether the patient is febrile, or he has just had a good run, he has had seizures, or the urine is very alkaline. So all these factors affect the dipstick estimation of protein. It detects mainly albumin. Then second method is urine protein creatinine ratio. So when we are saying protein, it means all proteins, not just selective protein, that is albumin. So protein is a general protein, all the proteins. Urine albumin to creatinine ratio, it is more specific for albumin. So why do we take the ratio of creatinine? Because protein or albumin excretion may vary. Day-to-day variation may be there, and with diseases also they may alter. But creatinine excretion is relatively fixed. So creatinine, for all practical purposes, it is 14 milligrams per kg body weight per day. Creatinine is a waste product, metabolic waste product of our muscles. So its excretion in the urine is constant. So one factor is constant, the denominator. The numerator can vary. So the ratio gives a true reflection of amount of albumin or protein that is being excreted in the urine per day. So this is, we all have done this in our biochemistry lab. We also teach our patients how to do this. There is a heat test method. So what do? We take a clean test tube and fill 2/3 of it with urine. We tilt it and heat it. Bring it to boil. So if there is a flocculation or turbidity present in the upper 1/3 of the test tube, the lower 2/3 remains the control. So we can be sure that some proteins are there, present there. But the test is not complete. We have to add glacial acetic acid and again boil. So if the turbidity disappears, it was just due to phosphates. If the turbidity cloudiness persists, then it is because of protein. This is a test which we educate all our patients of nephrotic syndrome to do the test at home, and they can be trained and they keep doing it. So this is how it is interpreted. That these are the various levels of proteinurias which are present on heat testing. It is negative, absolutely transparent. Slight turbidity is there, but once we put a paper or a print material behind the test tube, we are able to read. Over here, 1 plus proteinuria, we cannot read the print, but we can see that some lines are there behind. 2 plus, we are not able to see anything, just we cannot see through it. Then these are fine flocculations, and then these are heavy flocculations or coagulations. So if we do some interventions to prevent or reduce urine albumin secretion, what can be achieved? How can we do that? We can do that by reducing, controlling blood pressure, reducing our sodium intake, because even those people who take lot of salt start throwing proteins in the urine. Achieve good control of diabetes early, which may prevent albuminuria completely, reduce weight if we are obese, reduce protein intake if we are very heavy protein takers. We take non-vegetarian food 3-4 times a day, and if we have to stop taking tobacco. So these measures we can reduce urine albumin excretion. So diabetes is the most likely cause of CKD if albuminuria is present, and it is associated with diabetic retinopathy. And the patient has diabetes for a relatively longer duration, 10 years or more. But all albumins present in a diabetic patient do not indicate diabetic nephropathy, because these patients are prone for other nephropathies also, like membranous nephropathy. So if it is associated with diabetic retinopathy, then there are 90% chances that it is a diabetic kidney disease. Otherwise, kidney biopsy is the gold standard when we see under the microscope. So how do we define now microalbuminuria? this is the actual topic of today's discussion. Normally, only a small amount of albumin is filtered at the glomerulus, and most of that albumin is degraded and reabsorbed by the proximal tubule. And very minute quantities of albumin appear in the urine. However, a number of conditions can temporarily or permanently cause an increase in urinary protein excretion, either by altering glomerular membrane permeability, inducing glomerular capillary hypertension, or reducing tubular reabsorption. So, microalbuminuria is defined as the range between urinary excretion of albumin 20 to 200 micrograms per minute or 30 to 300 milligrams in 24 hours. So this reading is in use and we have to remember this only. 30 to 300 milligrams per day of albumin is excretion is known as, it comes under the category of microalbumin. So there is a difference between proteinuria and albuminuria as it is understood by the name itself. Normal proteins in the urine should not exceed 150 milligrams per day. This 150 milligram protein includes 10 horse protein, protein of blood group antigens, other proteins, and albumin constitutes only 0 to 30 milligrams of this whole 150 milligrams. So albumin in urine should not exceed 30 milligrams per day. The standard urine analysis, that is dipstick, however, can detect albumin only at levels greater than 300 milligrams. That is, when the readings come between 2 plus 3 plus, then the albumin excretion is 300 milligrams per 24 hours. But microalbuminuria can be accurately measured by several widely available sensitive methods like ELISA, radioimmunoassays, and liquid chromatography, etc. So now normal albumin in the urine is less than 30 milligrams per 24 hours. Microalbuminuria is a range of 30 to 300 milligrams per 24 hours, and macroalbuminuria is more than 300 milligrams in 24 hours. So the term micro and macroalbuminuria is actually misleading. Once one can understand that there are some different fractions of albumin, which are a small fraction or a large fraction. It is not that. Albumin is the same, it is the quantity of the albumin which is less or more for micro or macroalbumin. So now, in normal albuminuria, the report says if we are using dipstick, it will show it will be negative, like it will be blue in color. Daily urine milligram would be less than 30, and time collection you can do whenever we have to differentiate between orthostatic hypotension, orthostatic proteinuria. In microalbuminuria, urine dipstick will again be negative, and this would indicate albumin excretion less than 300 milligrams. And in macroalbuminuria, dipstick would be positive, and daily excretion would be more than 300 milligrams. So what are the causes of microalbuminuria? Certain causes are non-modifiable, like race, people of African origin. Males are more prone for microalbuminuria, elderly or low birth weight babies. Then certain causes are well proven. One is diabetes, hypertension, obesity, and smoking. Then likely to be associated with microalbuminuria, people taking high salt diet, high protein diet, having hyperlipidemia. In case of fever, convulsions, exercise, or congestive cardiac failure, when venous pressure increases, urinary tract infections, and vaginal discharges. So another classification of microalbuminuria would be pre-renal, that is exercise, fever, hypothermia, convulsions, venous congestions. Then post-renal, urinary tract infection, hematuria. These would contaminate, like pus cells and RBCs are again protein. So the dipstick will read them as proteins. It will not say the source is from the glomerulus. So these are the post-renal causes. And the most important one is the renal microalbuminuria, which is of importance to us, and we are discussing this one today.
Pre and post, they are reversible.
They would give, yes, they are reversible, they are modifiable, and renal microalbuminuria, it is a disease state. So before diagnosing of renal microalbuminuria, pre-renal and post-renal causes should be excluded. If we examine a febrile person and do his urine, it comes to be traced, then we needn't be alarmed that we have to wait for the fever to subside and then get the test repeated. So these are the different terminologies. Albumin to creatinine ratio in a random spot sample, 24 hours urine collection. This is a gold standard for seeing albumin or 24 hours urine protein, but it is very cumbersome. How do we measure this 24 hours, collect this 24 hours urine? It is very difficult. Suppose we have to start the collection at 8 am, say on 22nd of January. So we will instruct the patient that at 8 o'clock sharp he has to go to the bathroom and void. That sample needn't be collected, should not be collected. Then all through the day, whenever he passes urine, all samples have to be collected. Then on 23rd of January, 8 o'clock, he has to again go and void and collect that sample. So this would be 24 hours urine collection. So most of the time patients are not able to carry out this perfectly. And whenever we are writing this test of 24 hours urine protein, we have to also write 24 hours urine creatinine levels. Why? Because urine can be over collected and urine can be under collected. So suppose instead of 8 o'clock, he keeps collecting till 10 o'clock or 12 o'clock, and then he goes and gives the sample, so the protein levels would be high. Suppose he forgets, he voids 2-3 times outside, then the urine sent for 24 hours testing would be less in amount and proteins will be correspondingly less. But if we see the creatinine of that person, urine creatinine excretion, we can have a fair idea whether the urine is over collected or under collected, because creatinine, it is a constant factor, we can always calculate. And timed urine collection, this is done in special circumstances, 4 hours collection or overnight collection. So this is how cumbersome this 24 hours urine collection is. So to overcome this has become very easy, albumin to creatinine ratio. We can do it, ideally it should be done in the first morning sample. But it can be done anytime in a day whenever the patient comes to us. And what we have to ensure is that next time when we are repeating, that relatively same time should be followed for giving the sample. So first void or other morning collections are best because of the known diurnal variation in albumin excretion. If this timing cannot be used, uniformity of timing for different collections in the same individual should be employed. So this is an important slide and it clarifies all our doubts. So spot albumin to creatinine ratio. Normally less than 30 milligrams per gram of creatinine. Because creatinine is constant, only albumin would be changing according to the amount of albumin which is being lost by the glomerulus. So spot albumin normal is less than 30 milligrams per gram. Moderately increased 30 to 300 and severely increased is more than 300. So this middle figure is microalbuminuria because we have to do special test to catch this value. It cannot be done on routine urine microscopy, which we are doing always. Then spot protein to creatinine ratio. This value would be higher because it is microalbuminuria is thought to be the consequence of generalized endothelial damage along the vascular tree, including the glomerulus. That is why it is an independent risk factor for so many other diseases, which Dr. Agarwal will be telling us shortly. And enzymes involved in the metabolism of anionic component of the extracellular matrix, that is heparin sulfate proteoglycans vulnerable to hyperglycemia, seem to constitute the primary cause of albuminuria and associated complications. But as I said earlier, that only 30% of the diabetics have microalbuminuria. It is because of genetic polymorphism of this enzyme heparin sulfate proteoglycan. So what is the natural history of diabetes? Microalbuminuria is not usually presenting finding at the onset of diabetes. It's only after 5 to 10 years of uncontrolled diabetes, susceptible patients develop intermittent microalbuminuria and before having persistent microalbuminuria. So this is the natural history of a diabetic patient. So diabetes comes here in the body. First is only the functional changes which we have discussed. Stage 1, nothing happens. Patient will not control his blood sugar. He will say, "हमें तो कुछ नहीं हो रहा, हम तो दौड़ रहे हैं, खा रहे हैं, डॉक्टर बेकार है, बकवास कर रहे हैं, शुगर कंट्रोल करो." He is happy. Then gradually, it is a silent phase where the structural changes start occurring. Then it is incipient nephropathy after 5 years. At this time, incipient nephropathy or stage 3, microalbuminuria start appearing. At this stage, if the patient gets alert and the physician is able to counsel the patient to take care of his blood sugar, this from stage 3 we can always step down and revert back. Patient doesn't listen, continues with all Ayurvedic medicines and Jamundi Gutli and all this. So gradually this incipient nephropathy converts into overt nephropathy. And at this stage, even urine protein microscopy will show albuminuria, proteinuria. At this stage, blood pressure also starts developing in these patients. And at this stage, retinopathy can also be detected. Still, the journey goes on, and after 2-3 years of this overt nephropathy, the renal function starts declining. And it is a matter of 3 to 5 years that the patient enters this ESRD stage, or that is stage 5, and has to be then offered dialysis and transplant. So till stage 3, microalbuminuria can be reverted, and this we can prolong. That it is taking 5 to 15 years, we can push it to 30 years, and so much of life and good health can be achieved. And then the same this natural history same in type 2 diabetes also. But the problem with this type 2 diabetes is that it enters our body earlier and it is detected later. So a period of 6 to 9 years elapses before diabetes is detected in that patient. So type 2 diabetes always, most of the time, presents with complications. A person has to, 65-year-old goes for a cataract surgery, there the sugar is done and that person is detected diabetes for the first time. But then if we investigate the patient further, he will be having some degree of renal failure, some degree of cardiac involvement, all these would be present, hypertension will be present. So type 2 diabetics present with complications. Because we are not in the habit of getting our health checkups done yearly basis as advised after the age of 40. Subjects often present with microalbuminuria at that point. However, diabetic nephropathy in type 2 diabetes is similar to nephropathy in type 1 diabetes. The only difference is that it is detected late. So same things happen over here also. Functional changes, structural changes, rising blood pressure, microalbuminuria, proteinuria, rising serum creatinine levels and end-stage renal disease, and along with that, cardiovascular deaths, morbidity and mortality is also associated with type 2 diabetes. So all these patients, suppose a diabetic patient is detected to be having kidney disease in very incipient stage, it is, suppose 100 patients are proceeding, are there, only 20 will reach this stage of dialysis or transplant. 80 in between will die because of cardiovascular complications. They will have a heart attack or a brain hemorrhage. They will die. They will not reach the stage of end-stage renal disease or stage 5 of kidney failure. So any